Hey there everyone, and welcome to part 3 of our discussion on neurologic conditions. Alright, so more neuromuscular diseases. We're still talking about multiple sclerosis. So in diagnosis of MS, there's no specific test, it's more of a cluster of things. This is part of why it can take a while for a diagnosis to actually occur. So one of the things they do right off the bat is they do a lumbar puncture, and they look at the CSF, and they're looking for something called oligoclonal bands, which show immune activity. There are formal criteria to look at like the cluster of things that are considered as part of diagnosis of MS, like formal diagnosis. And one is that you have to have 2 or more distinct attacks, an attack being a reduction in strength, balance, tone, and similar. 2 or more lesions in the central nervous system that show on an MRI. This is to the brain or spinal cord. CSF can also show those oligoclonal bands like we've got there in the purple. And then they need to rule out everything else. So this is still somewhat a diagnosis of exclusion. You can see in the imaging here, the bottom bit here, oligoclonal bands are absent, and then you see them present here. So that's how they look at the content of the CSF. On imaging, they'll do MRI, and the scar tissue is often, they'll call it plaques, and that's caused by the destruction of the myelin. There's different forms of MRI. You don't have to know the different forms and what they show. I'm just kind of showing you for exposure. I'm just telling you that MRI is how they catch it. So let's take a look at MRI here. And this is an individual who's 30 years old, so right in the age territory. A little bit different on the biologic sex in that they're a man, but it does happen. And this individual, see the flare here? Okay, so what you're looking at right here is this one here. This is easy to see. See these bright points? They call that flare. So this is an MRI with flare. And that's showing some of the injury, right? And then they do other things to look at aspects of the plaques or the scars. This is showing it in the spinal cord, because again, the spinal cord is part of the CNS. We do know that individuals who have plaques on the spinal cord tend to do more poorly because it tends to take out weakness to a stronger degree, or it tends to create weakness of a stronger degree than it does in the brain. And so you can see the plaques at different points where the arrows are showing. So definitely a frustrating diagnosis. Because the plaques can occur anywhere in the brain, it's basically you throw a dart and that's the clinical presentation. However, there are tendencies. A big one are actually motor presentation, and that's going to be weakness, spasticity, hyperreflexia, and general upper motor neuron signs. Again, this is a CNS diagnosis. Sensory, all over the place, right? Paresthesias and loss of sensory components, as well as altered pain that's usually described as burning or tingling, usually in the feet or sometimes the arms. Vision is often impaired very quickly. Blurred vision is sometimes how this diagnosis gets caught. And then they also have vestibular issues such as oscillopsia, which is a perception that the room is bouncing and jumping in front of you when they know that it's not. Color gets weird. They have issues with eye control. They can have weakness of extraocular muscles, resulting in ophthalmoplegia. Heat intolerance. This is a classic here. So neuro in general has mild heat intolerance, but it's notable in some conditions, like more iconic, if you will. So in MS, that's definitely true. They hate the summers, particularly if you're practicing here in Texas. So any sort of increase to core temperature, in other words, if they're trying to get in a good workout, or it's warm weather. The reason this happens is actually kind of interesting. It's called the Uthoff phenomenon, and it's where an increase in body temperature increases their neurologic symptoms. I pulled literature on this a while ago, and they think that increased temperature decreases nerve conduction and partially demyelinated fibers, which is really interesting. So heat, not great in MS, definitely not. So no hot tubs for them. Fatigue, serious fatigue issues. So there can be what they call primary MS fatigue, and then because they're not able to move as much, you end up with deconditioning, disuse atrophy, their sleep is bad, their mental health is bad, all sorts of things, right? Otherwise, though, they can end up with a phenomenon in central nervous system issues called central fatigue. You're going to hear this a lot. It goes across the board for all neurodiagnoses, but it's usually most notable in MS. Central fatigue is an issue where the motor pathways aren't able to activate if you're asking of them over and over again. So in other words, if you wanted them to do 20 reps of a bicep curl, and the last 3 or 4 reps they might not be able to do, and that's central fatigue. They might be perfectly motivated, temperature's great, they slept well, mental health is good, everything's fine, but it's just toast, central fatigue. Okay, so you're going to see that sometimes. Otherwise, though, you can assume that there is an element of decreased motor unit activation due to the issue of lack of the brain able to tell the lower motor neuron to fire, right? Ooh, it loves to hit the cerebellum. Very, very common to have cerebellar issues of ataxia, incoordination, dizziness, and imbalance in MS. And then you get this neurogenic bladder issue, and so a lot of incontinence, incomplete emptying issues, and a lot of bowel and bladder frequency, particularly at night, which of course hits their sleep even harder. Because they don't empty out their bladders all the way, because the bladder is more spastic, they're more prone to UTIs. And then with all of this going on, this is a terrible, awful condition, and so they get very sad. In addition, there might be plaques in the areas of the brain regarding emotional regulation, so from top to bottom, there's a lot of cognitive and emotional issues. They're also fairly forgetful. Okay, so let's come back to the types briefly here. Okay, so we talked a little bit about relapsing remitting. This is by far the most common one. Observe this red line here. So it goes worse, and then it gets better. It gets worse, and sometimes the worse gets deeper, and then it comes back up. That's pure relapsing remitting, okay? Over time, as the plaques build up, they don't come back up to their baseline. The new baseline keeps getting lower and lower, and as that starts to happen, the relapsing remitting diagnosis converts to secondary progressive. There are two other major types. One is progressive relapsing, in which it just keeps getting worse, and suddenly there's a huge decrease in function. It gets a little bit better, but then they start decreasing again. And there's primary progressive, where it just keeps getting worse without any clear spikes in either direction, and malignant, which will kill you by the time you're probably 30. So those are much rarer. The vast majority of cases you're going to see are relapsing remitting, and as they get older, sometimes secondary progressive. Total number of times I've seen malignant is only once, and primary progressive I've only seen 3 or 4 times. I don't think I've ever seen progressive relapsing. So maybe they just weren't diagnosed yet, right? Because it can look initially like primary progressive, and then you have a relapsing episode. So at any rate, the others are quite rare. Okay, so again, to go through them in words, relapsing remitting comprises the vast majority of diagnoses, and the return to function or the return to baseline is either complete or partial. The relapse lasts between 1 and 3 months. Over time and with age, and I mean decades, the relapses get more severe and they don't come all the way back up. Secondary progressive is generally the geriatric presentation of relapsing remitting as it progresses more, and so then the diagnosis converts. And unfortunately, the worsening of symptoms sometimes happens at a faster rate than in their youth. Primary progressive, no relapses, no remissions, it just gets worse all the way down. And then progressive relapsing is the same thing, but with a spike downward. Malignant, it's just faster than primary progressive. So any diagnosis of MS will probably shorten your lifespan by at least 6 years, according to the literature. If you have relapsing remitting, that's the best prognosis. And the gentler your presentation at onset, the better it's going to go. Negative prognosis is, of course, the more aggressive stuff, such as primary progressive, or they're older at onset. If they have early cerebellar or pyramidal signs, if they smoke, social determinants of health play a role. In other words, your patients who are African American are more likely to have a worse go of their condition. If they're male, or if they have low vitamin D levels, which is interesting. Early diagnosis and treatment is king. Seriously, this is tops. I have had patients with fairly decent secondary progressive, and yet it's surprisingly stable. So I had one person secondary progressive where they had managed to get something like perfect medication management. This patient was very motivated and did a lot of individual research that was actually accurate. Sometimes when patients do their own research, it's debatable effectiveness and accuracy, right? This patient was really smart and actually was doing a really good job of taking care of themselves. And they were good at advocating for themselves, saying, hey, no, really, this is serious, take me seriously. In addition, they had the best med for their particular manifestation of MS. And so at the time I was treating her, she had not had a relapse in 5 years, and she herself was 73 years old. That's amazing. That's remarkable. I'll probably never see that level of excellence and care again, but that's what it is. Seriously, if you can get the medication management just right and get some good therapy going and some prevention, they can actually come into a really good stable pattern. It's just management rather than having to deal with the relapses. So that's an ideal situation. Otherwise, when they do relapse, they're going to throw massive doses of corticosteroids at them to get the relapse to end quickly. They're trying to turn off all that inflammation, because in this case, inflammation is destroying their myelin and eventually their axons. Otherwise, they're going to turn down the immune system with DMARDs. So the goal here is to reduce the severity and number of relapses and then try to prevent new areas of damage from getting worse. And you're trying to slow the progress of the disease to prevent disability for as long as possible. So these are folks who are probably still wearing masks if they're grocery shopping, or if a family member lives with somebody with MS, they're probably still wearing these, and they may for keeps. I mean, COVID isn't going anywhere. Let's switch over to another diagnosis cluster. So this is going to be Parkinson's disease and Huntington disease. These are both really big movement disorders, with Parkinson's disease being the big one. So this is a progressive chronic disease of the CNS characterized by its presentation, rigidity, tremor, bradykinesia, and postural instability. This is the most common motor disorder in the US. And it's more common than you'd think. And PT is huge in this condition because it's a motor disorder. So the epidemiology, it's 1% of your folks over 60 across the US. So that means there's upwards of 1 million people right now in the US living with Parkinson's disease, and that population is larger than everybody with MS, muscular dystrophy, and ALS combined. So this is far and above the most common neuromuscular disease in adults. The etiology, we still don't fully know, but we're learning more and more. So there's 3 primary sources. One is genetic, one is exposure, and the other is head injury. Head injury we've become more aware of in the last few decades, and I have 2 individuals there. That's the boxer Muhammad Ali and the actor Michael J. Fox, who both have Parkinson's disease. Muhammad Ali's is thought to be from head injury, and they don't know Michael J. Fox's, but I believe his is thought to be genetic. Parkinson's runs in my husband's family, and there's a very clear line of inheritance there. Exposure is another factor. So most of your exposure folks are going to be older, and a lot of them are actually veterans from World War II and Vietnam. So with Vietnam, there were chemicals used in Vietnam, which is a country with a lot of jungle. And back in the day, the U.S. thought it'd be a great thing to try and burn all the plant leaves away to try and, engage in war. And it turned out they were doing that on top of people too. So those veterans now have Parkinson's, and that's an herbicide/defoliant exposure. So that gives you a sense there. So genetics, environmental exposure from chemicals, bad chemicals, and head injury are the 3 things, okay? Possibly in combination, possibly not, but there seems to be something in there with that. Men are more likely to have Parkinson's than women by a factor of 1.5. And so if you think about it, head injury and exposure, more likely, just culturally and in terms of epidemiology to happen to men than women. Pathogenesis, what's actually happening, this is degeneration of a basal ganglia structure called the substantia nigra. Neurons in there produce dopamine. So if you take a look at the image here, see the dark bit here? That is the death of those neurons. So this is the basal ganglia, and this here is the substantia nigra neurons. So that's what you're seeing here. So that's the loss of pigmentation that's occurring. This is it normally, and this is it pathologically. So you can see that they actually have a dark coloration normally, and this is it here with that happening, with the loss of those pathologically. So it doesn't seem to be perfectly just the loss of these neurons. There's more to it than that, but this kind of simplified explanation gives you a lot of insight. This is a lot of purple hexagon to give you more insight for those of you who like to understand more of the finer tuned pathways of the role of the basal ganglia and why loss of dopamine creates the presentation that it does. I'm not going to test you on any of this. If you're interested, come find me in office hours and I'll walk you through it. It's actually going to take us about 25 minutes to get through it. It's decently complicated, but suffice it to say, dopamine causes movement. The lack of dopamine results in reduced movement, and therefore you have the presentation of Parkinson's. The opposite of this is the reverse. An excess of dopamine causes too much movement, and that is Huntington's, okay? So that gives you a sense of the pathophysiology as a result of the etiology of losing dopamine. So we're losing dopamine. We don't have enough movement. So it turns out there's a lot of forces in the basal ganglia, and the basal ganglia does 2 things. It turns off unwanted movement and turns on wanted movement, okay? So when it's lost its neurotransmitter, you get some unwanted movement, and one of those is a resting tremor. So they're at rest, which means the limb shouldn't be moving, and yet it is. So this rhythmic involuntary shaking in the finger or hand when it's relaxed is called a resting tremor. In one of its stronger, more iconic manifestations, you get a pill rolling movement, which I'll demonstrate during class. Again, remember that lack of dopamine means lack of movement, so they get bradykinesia, which is less movement or slower. They become unable to walk steadily, unable to perform rapid rhythmic movements, and eventually they come into freezing, in which they have to try and transition between, say, carpet and tile, a change in texture or look of the floor, like the visual look of the floor. Like, say, the colors are different. The tile is gray and the carpet is, red or something. They have difficulty transitioning between visual flow of the floor in terms of colors and patterns and things, and they'll freeze. They can't move at all. It's immensely frustrating. They also have an issue with rigidity. So this is a stiffening of the limbs, and they'll have difficulty with swinging their arms while walking, getting out of a chair, and eventually this tone rises to the point of it doesn't move at all. The terms for this are called lead pipe rigidity and cogwheel rigidity. We'll talk more about this during class, in which I'll attempt to demonstrate. We'll watch some videos with it. There are other traits that are not part of the established criteria, but they absolutely are part of what we think of it. So in other words, these bolded things here are more the cardinal signs and symptoms. These are elements that tend to be there but aren't always. One is postural instability, and this tends to happen a little later in the course of the disease, and that's a huge area for PD to treat. They tend to have a stooped posture as a result, and the rigidity gets into the spine as well and makes that worse. And they tend to go backwards with certain movements, which we call retropulsion, and creates a lot of fall risk as they start to age further into the diagnosis. They also tend to have a gait pattern that is, again, not everybody gets it, but some do, and it's more kind of further into the diagnosis, in which they move robotically. The formal term for that is en bloc. They stop swinging their arms, they stop moving their hips, and they have this tiny little stride length that we call festination. I'll do a demonstration for you during class, and we can watch here in a second with this particular video. Okay, so I'm going to go ahead and play a video here of somebody walking who has a Parkinson's diagnosis. I want you to pay attention. Notice that the arms are not swinging, the tiny little stride length, hips are not dissociating. Yeah, it's a very classic Parkinsonian gait. Oh, so stiff as we turn. Ooh, a little bit of freezing. And then we keep going. Those ankles are very stiff. So next we come to resting tremor. Again, this is a tremor that goes away when they're actually using the arm for a task. In other words, when the arm is at rest, there's a tremor. When they're in motion, it's not there. So reaching to pick up a book, the tremor fades. Then they do something else and their hand is at rest on the desk, the tremor returns. Okay? So the tremor goes away when performing voluntary movement. Let's go and take a look at that here. I'll get another video up. So at rest, this is what they're doing. Observe that it almost looks as though there is a pill in their hand that they are rolling between their fingers. This is the classic resting tremor with pill rolling. Sometimes it's more profound than that. But yeah, the hand just keeps going. They don't mean for it to, it just keeps going. So there's a lot of non-motor presentation attributes for Parkinson's disease, but there's only some that I want you to be most familiar with. One is orthostatic hypotension. So they sit to stand or they stoop to stand, and they tend to pass out sometimes. They also have issues, very profound issues with multitasking and concentration. Dual tasking is quite challenging for them. Mood changes are quite notable, and later on into the diagnosis, they actually experience visual hallucinations, paranoia, and delusions. That can be extremely troubling to caregivers when somebody keeps screaming because they think a ghost is in the room. They also have issues with swallowing, which means that they build up a lot of drool in their mouth. And similarly to ALS, sometimes you'll see these red streaks or kind of skin breaking near the corners of the mouth in kind of like rivers that run down the chin because they're constantly drooling, and the presence of soft, wet stuff on the skin all the time breaks down your skin a little bit. So sialorrhea is a real issue for them. And then that's also an issue socially. Nobody wants to be seen with drool on their mouth, right? Okay, so what do we do for this? Well, the big thing is medications, and we'll talk about this more this summer when we come to our pharmacology conversation. But there's one main drug I want you to be familiar with. It's called Sinemet. It's a combination of two things, carbidopa and levodopa. You usually hear that all kind of slurred into one thing, carbidopa, levodopa, because you'll say it all the time. And the way it works is by increasing available levels of dopamine. Now, dopamine is a neurotransmitter, and so you can't just kind of willy-nilly increase the levels of that and expect there not to be side effects. The side effects are significant. You don't need to know them yet, okay? So there's two issues, though, with this thing. One is that while it does raise up dopamine levels, a lot of side effects, and then over time, it stops working consistently. And so you end up with these on time and off times in which it's working really well and then not as well. So it cycles on and off, which is really frustrating. Unfortunately, this is the best we've got. So side effects are profound, and eventually it stops working as well, which means a lot of times folks, they don't always respond to medications in general, or something stops working so well. The surgical option is to create an electrical stimulation in the brain. So they do neurosurgery, they open you up, they place 2 electrodes way, way, way deep down into the subthalamic nucleus, the globus pallidus interna, and the thalamus to stimulate and kind of replace the actions of the basal ganglia. They're not actually damaging brain tissue, and they can't actually remove everything. And the stimulation levels and frequency can be changed through basically a remote control that is nice as the disease progresses and changes. This is not complication-free. It's very expensive, and it's still kind of debatable if it works great. I can say that when it does work great, it looks amazing. People are immensely satisfied. So it's kind of, I feel like it almost goes into extremes. Either it doesn't seem to work very well, or it works like magic. So that's one thing to be aware of. And then the progression of this condition. So this particular condition has 5 stages. You do not need to know them by number. What you do need to know is the general sense of what it looks like early versus later. So early on, it tends to let someone still do their daily activities in one side only. It then progresses to both sides of the body. Things kind of slow down. As it hits the mid-range, they start to get more impaired and falls start to become more common. This is typically when they come in for PT, when the falls start. Later, you start to need an assistive device, and they're no longer able to live alone. So once the falls start, that might mean that we're coming up to needing a walker and no longer being able to live on our own. And in the latest stage, they're wheelchair or bedridden, and that's when the psychosis type events begin to happen, the hallucinations and delusions. So at end stage, this is a very sad thing for folks as they deteriorate, which means we really want to catch it early, because catching it early gives us more options for treatment and more time to figure out what we're going to do. I think it's very important that PTs be able to recognize the signs and symptoms of Parkinson's disease, because, let's jump back over here to medical workup. Guess what? There is no specific laboratory or imaging study that can make a diagnosis. The evaluation is 100% dependent on history and physical exam. Guess who's really good at that? PTs. Yes. So that means you are perfectly capable of catching things just like a physician can, which means you're a powerful source of targeted referral. So these are the early signs of Parkinson's, and some of them are more in the area of the cardinal signs and symptoms, such as the tremor, but some of them are a little more subtle or a bit less obvious, such as the micrographia. Micrographia being they start writing really, really, really small, and sometimes their voice gets really soft. So these things, these matter. Myself, when I was a physical therapy student, I was on my 2nd rotation, and I was in an under-resourced hospital in Metro San Antonio, and I caught 3 cases of Parkinson's disease in the 8 weeks I was there. So just as a student, doing my due diligence, having learned a slide similar to this, I was able to make those referrals, and eventually diagnosis was made each time. So all that means is you basically already possess many of the skills needed to catch this early, which is a really good thing. That really helps out our patients. So I just want to emphasize to you again, the tremor, you can watch this video if you like, otherwise we're going to watch it during class, that the resting tremor is what we're looking for, not the action tremor, okay? And then prognosis varies quite a bit, although you tend to have a while, upwards of 2 decades or so since diagnosis. I'd say the bigger issue here is actually the dementia that sometimes happens hand in hand with this. And then a lot of times there are a lot of issues secondarily as immobility rises and all the immobility complications, particularly with later stage Parkinson's. So all those things to happen when you don't move, DVTs, PEs, pneumonias. So those are more likely to be the issues from that. So let's go ahead and pause here, and we'll transition over to the next part.